My name is Christopher Jabara, and I'll be presenting a rare recurrence of Takotsubo's cardiomyopathy resulting from a different stressor. Stress cardiomyopathy, or Takotsubo, is described by transient regional systolic dysfunction of the left ventricle in absence of angiographic evidence of obstructive CAD. It is an uncommon etiology of acute cardiomyopathies in males. Up to 90% of cases occur in older females. Although risk of reoccurrence of stress cardiomyopathy is as high as 2% per year, the cause may differ from the initial event. 80-year-old male with a past medical history of coronary artery disease with stenting, peripheral neuropathy, and stress cardiomyopathy in 2013 presented with mild chest discomfort, chills, and rigors. On admission, he was febrile to 39 degrees Celsius with hypotension, which responded to 1 liter of IV fluids and was started on broad-spectrum antibiotics. Initial cardiac troponin was 3.4, and EKG showed Q waves in leads 2, 3, AVF, and T wave inversions in AVR and AVL. Repeat troponin was 17.3 with T wave inversions throughout the precordium on a repeat EKG. He was initially treated for an NSTEMI with a heparin drip. On echocardiogram, he was found to have an ejection fraction of 15 to 20% with anteroapical akinesis and ballooning. He subsequently underwent a left heart catheterization which revealed a 50% in-stent restenosis of the RCA but was hemodynamically insignificant with an IFR of 0.98. His blood culture eventually grew pan-sensitive E. coli. Heparin drip and optimal medical management per congestive heart failure guidelines was initiated. The patient was recommended for close follow-up with cardiology at discharge. Of note, his initial stress cardiomyopathy episode was triggered by a family member death and emotional stressor. It's important to recognize that multiple forms of stressors can trigger Takotsubo's cardiomyopathy. Our patient had a reoccurrence in the absence of identifiable external stressor but was triggered by bacterial infection. Diagnostic criteria for Takotsubo's cardiomyopathy include transient regional wall motion abnormalities not in a single coronary distribution with absence of angiographic evidence of obstructive CAD, new EKG abnormalities, or moderately elevated troponin in the absence of pheochromocytoma or myocarditis. The exact mechanism is unclear, but is related to stress-induced catecholamine excess leading to cardiac toxicity. Understanding that most patients have resolution of reduced EF within 1 to 4 weeks if the stressor is removed, it's important to have close follow-up that include repeat echocardiogram within 3 to 6 months. Also, clinicians should inform patients of their increased risk of reoccurrence despite removal of external stressor. Clinical suspicion of stress cardiomyopathy, even in recurrent events, should not alter evaluation and management of ACS.